Good morning.
Good morning, Jack.
Can you hear us?
Can you hear us?
Yes, we can hear you.
Yeah. Welcome back to our cath lab, King Chulalongkorn Memorial Hospital. I'm Dr. Support. With me, Dr. Ponte. And Dr. Koi and Dr. Ying is our operator and our fellow Dr. Sup. And we also have Dr. Sudarat behind the canteen. She's an echo guide for this session. Yeah. And we also have our team. Yeah. So I will present you the case today.
Yep, okay.
Hello, welcome. Today I will introduce the case. He is a 47 years old male. He presented with dyspnea on exertion for 1 week, and he had a sign of congestive heart failure. The physical examination showed that he had the continuous murmur at right upper parasternal border. The next slide, please. Okay. And he has also had 5 crepitation at both lower lungs. Next slide, please. His ECG showed that he has normal synapse rhythm and complete right branch block. Next, please. This is his transthoracic echocardiogram, which shows that he has the LV dilatation and the moderate LV dysfunction. From the aortic valve, we'll see that the echo drop out in the right coronary crust, which it has continuous flow from right coronary crust to right atrium, which compatible with rupture sinus of Valsalva. And Dr. Sudarat, which is an echo specialist, will demonstrate us the transesophageal echocardiogram.
So echo, please.
So we can see the TOE, but no sound yet. Sudarat, we can't hear you.
Okay. I'm here. Do you listen to me?
Can you hear Dr. Sudarat?
Can you hear me?
Nope. Is she speaking?
Can you hear me?
Oh, now we can.
Yes. Okay. Okay. Thank you. This is a transesophageal view. Again, TE4 chamber view. This shows veins of appearance of right coronary sinus aneurysm. And there is a rupture sign from right coronary sinus. Right aortic sinus aneurysm rupture from aorta into right atrium. And the rupture size diameter is 3.5 millimeters from 2D measure. And from the colorful guided, the rupture size diameter is 3.9 millimeters. Yes. Okay. I'm done.
Okay, next slide, please. This is the right heart cath that we just performed here. You see that he has the pulmonary hypertension, and let's see at the oxygen. We'll see that the oxygen step up in right atrium, which step up from 62% to about 70%. We calculated the QPQH, which was about 1.3. However, we think we will close the defect because he have the symptom and he have the LV dysfunction. Next slide, please. We also perform the cardiac CT, and we reconstruct it into the model here. You see in the right side of picture that there are the defect here and in the right conicus of sinus of Warsaw, which turn into the RA.
If you could just
we also
if you could just hold that, because there's a lot of
Yeah.
detail there, just for a second, because I'm going to ask Nick Haas for he's got a question or a comment for you. Nick.
Thank you. Thanks for presenting the case. What I do not understand is this very bad left ventricular function in this patient. I mean, this, if you look at the echo, the long axis, that's a fraction of shortening of 15 or something like this by eyeballing, or 20, which is far too low. And for me personally, the additional volume load does not explain this at all. So, and the pulmonary hypertension with the diastolic pulmonary arterial pressure of 26 or so indicates high capillary wedge pressure. So is there anything else other than this defect in this patient? I mean, yes, we have to close the hole, that's a different story, but
Okay, so we'll address some of those points from Nick.
You correct. The LV function is very poor. Yeah. We treat the patient with the guideline-related medical treatment, and we work up with the LV dysfunction, and we cannot find any cause of LV dysfunction. We do the coronary angiogram is normal. And we do the MRI cannot show us the cause of LV dysfunction. But I think that the LV dysfunction may be myocardial disease plus the LV rupture sinus of Warsaw.
yes, biopsy would be interesting. I mean.
Yeah, we don't have a biopsy at this time. Yeah.
Okay.
But we think that we have to close it to reduce the LV volume load. Yep.
So now if you keep going through the slides and show us the rupture.
Yeah.
Thank you. Okay. Please go on to the next slide. Okay, we see that the defect was about 3.35 by 6.8 millimeter, and here is the real thing. We will print it to the model, and Dr. Pontep will demonstrate us the model.
Before we put something in the model, what do you think about the case? This case, have you close it if we need it, and which device do you recommend?
Okay.
For us?
All right. Let me just pick on Haysam. To close or not to close, and if so, what with?
Yes, thank you. It's a very interesting and very nice demonstration of the 3D. I would go ahead and close it. I think it's important to rule out any possible causes for this LV and pulmonary hypertension. That might be part of it, if not all of it, so we have to rule this out. Closing it, I think the best thing that we have so far in the market for this would be an ADO2. The size of it, with it being almost 4 by 6, I probably would go somewhere in between, like a 5 device. There is a 4.4 or 5.4 or 5. I wouldn't want to use something long, like a 6 millimeter width. So I would stick with the 4 millimeter. So there's a 4.4. I'm not sure if there's a 5.4, but I wouldn't go too big into a 6.4, for example, because you don't want to have a 10 millimeter disc on the leaflet.
Right, Shabana?
Yeah, I would agree with closing it. I truly don't understand the ventricular dysfunction. I'm not sure this is causative. It probably, probably increase PA pressures a little bit, but not the wedge pressure by itself. I would actually choose an ADO1 for this. It's a single hole, so I think an ADO1 is well suited for this kind of anatomy itself. Yeah.
Okay, Jean Antonio.
Yes, sir. I would close it, and I will remeasure it once the delivery sheet was already on the defect. I remeasure it. I probably go with 6.4 or 7.5 with multifunctional occluder.
Right, MFO, Sanjeev?
I'll go with a single disc device, ADO1. I would like to upsize a bit considering the redundancy of the tissues because of the rupture. Rather than 8.6, I would go for 10.8 or an 8.6, depending on the findings again on angio.
And also, how much does the disc size on the aortic end matter in decision making because of the proximity to the aortic valve cusps. That's an additional bit of information that we probably ought to see on TOE. Yeah, Nick?
This is why I would go for an Occlutech paramembranous VSD occluder, which is flatter and it's used to have the high pressure difference between left and right ventricle, and the disc is not too big as compared to the filling of the hole.
Yeah, Bharat?
No, the question I wanted to ask was, we have made these measurements at the point of exit, and as you know, this is a windsock kind of deformity. The question I want to ask the operators as well as the panelists, which is the right place to close this defect? At the mouth of the fistula or at the exit level? The reason I ask you this question is if we try and block the exit, my concern is that we may leave behind a cul-de-sac, which over a period of time could actually increase in size, and then you have issues of thrombus formation, coronary embolization, so on and so forth.
So that's the area we need to see more on live
I think
TOE.
so, and that's where
don't
we need to make measurements, because I would believe that I would try and close it at the entry rather than at exit.
Okay, Nageshwar?
Good case.
So I will show you the angio. Perhaps you have
got
more
one more
decision.
Sorry, Suport. One more question or comment here.
LV dysfunction can be explained with acute rupture. That itself can cause volume overload and generally PAH and LV dysfunction. The second point is there is already pre-existing AR is there. So the defect is bigger, even though it is measured 6.8 long. The effective orifice is definitely bigger. Here putting a ADO1 will actually stretch and stent, and aortic wall distortion is possible. The AR may progress. So therefore, I feel that MFO without stenting the defect, leave the complete LV disc in the aortic surface and put in RV disc, we have done in the past, will give you very good result.
Okay, that's helpful. Suport.
Just a quick comment on the ADO1. If you're choosing ADO1, that means you have to go retrograde from the atrium, which I think probably will make things much more longer and complicated rather than going from the aorta directly, which will go straight through.
Yeah, certainly can challenge, but at least looking angiographically, jumping a step ahead, I think any of those devices, it doesn't seem like the biggest windsock in the world.
Okay, so just talk us through the angiogram and the measurements, because I can't see them. Oh yeah, I can now. Yeah, go ahead, Suport.
Yeah, the opening of the aneurysm is about 6.5 millimeter. Yeah. And the rupture size at about 3.5 or 4 millimeter.
And
And
on
we
TOE,
have another one.
on transesophageal echo, do we see some sort of a windsock appearance that Bharat was asking about? Or we don't? So Dharat?
Yeah. You can see, please show TE, please.
No, we don't see the TOE yet.
Yeah.
No.
Can you show the big echo big?
Yes, okay. You see, this is a esophageal 3D echo. I can measure the rupture size from RS perspective. The size is 8.9 millimeters plus 5.8 millimeters. And from the aorta perspective, the size is 8.7 and 4.9 millimeters. It's a little bit bigger than image CAT and
Okay. But also, there's
3D
no,
printing.
from what I can see, there's no windsock appearance. Is there? Nothing flopping around.
Yeah. And this is another angio. I'm not sure that you see the angio or not. Yeah.
Now we do.
Yeah. Yeah. After we put the catheter cross the defect, and we make another angiogram, and we measure it's about 7.2, 7.1, yeah, something like that, for the opening. And for the rupture size, it's about 4 millimeter. Yeah.
Okay, so from the views listening to everybody here, you can pick any device you like, really. Any of those would work.
Yeah, I will, yeah. Dr. Pontet.
I think if we imagine this case is a PDA case, it's like a tunnel, and aortic opening is about 7, and the opening in the right atrium is about 4. But what I am not sure about the tissue in the sac, that is soft or not. So I think for me, as someone has already mentioned, I think I will use ADO1 and upsize the RV opening by 4. So with the device size of 8/10, the RV end of the device will be 8, and the aortic end is 10,
Okay.
and the disc is 16.
So Pontep is suggesting 10/8 ADO1. Right, let's just check
Yes.
with the panel.
Yes, yes.
Shabana first.
I would have gone with an 8.6.
8/6. Haysam.
I would go with ADO264.
Oh, ADO2.
6 diameter, 4 width.
Okay, ADO264. Tanabat. Microphone.
I agree for 10.8.
Which one?
10.8.
10/8. Okay, Sanjeev.
As early, 10.8.
10/8. All right.
I
Yeah.
would upsize to 8.6, the MFO.
8/6. So we are being totally unhelpful. We've got two 8/6s and two 10/8s and one ADO2. And in the audience, show of hands, number 1, ADO1. Okay, ADO2, much smaller number. MFO, also smaller number. ADO1,
I
we
don't
said,
think Nageshwara's vote counts at all.
Oh, all right.
Yeah.
Nageshwar, jump up and down. All right. And on ADO1, 10/8. Okay, 8/6. All right. Looks 6/4. 2. All right. Looks like 10/8. 10/8. ADO1 seems to be the preferred one. So, what have you decided then, Pontep?
Yeah.
Okay, we already choose 10/8,
Okay.
but now we are going to advance the delivery sheet, 7 French PDA sheet into the aneurysm. But at this moment, I cannot pass the sheet. And some stick.
Yeah, it might be helpful to have something over the wire from the aortic end and use a kissing technique, just like we would use in a
Yes.
VSD closure
Yes.
to smoothen that transition. And I guess similar points in terms of the wire course and everything not having gone through tricuspid.
And is this a Terumo wire or is it an Amplatz wire?
It's
It's a regular wire,
Right.
Which? Regular.
exchange regular wire.
Okay,
Yeah.
It's
we
going.
cross it. I
we
think.
cross it already.
Yeah.
There you go.
Okay. Yeah.
So is it worth repeating an angiogram just in case you need to downsize to 8/6?
I see. You want another angel? Yeah.
Well, it was just now that you've got 7 French sheath in, which is 2.5 to 3, whether
Okay.
there's a lot of flow around it, in which case 10-8, and if there's hardly any, then 8-6. No.
Yeah. Okay.
I mean, if it's difficult to do an angiogram, then carry
Yeah.
on.
We make another angel for you. Yeah. Okay. ได้
Yeah.
ได้ละโอเคพร้อมนะต้นชุด
Okay. Stick with the original decision then.
ต้นเอาสีเพิ่ม
Yeah. And whilst we're doing that, can you see anything on TOE now that the sheath is through? Whether there's any distortion of valve leaflets or anything like that? Bharat?
No, a couple of things. One is that, I would like to see how the tricuspid valve looks on transesophageal echo when they are crossed with a sheath. And second thing is, I think at least angiographically...
Hang on, Bharat. They're not across the tricuspid, are they?
No, but they are through the, they are close to it. It's probably in the anterior 1/3 of the non-coronary cusp.
Okay.
So probably close to the annulus, just to see.
Okay.
And the second thing, I was wondering whether this shunt is truly 1.3:1. Angiographically looks a rather significant shunt.
Yeah, looks small. Joku?
I think this case maybe 8001, 6/4. 4/6 maybe educate.
Yeah,
Because
okay.
if the disc too large, maybe the coronary artery ostium is just around.
Yeah. Okay, good point. So let's see. Can we have a quick look at the TOE and the color, and also look at the tricuspid valve?
Yes.
Yeah.
Okay.
So not far from the tricuspid.
I do think that's a benefit of using an ADO1 and, in a case like this, having a disc not stay on that septal leaflet of the tricuspid valve.
Okay, Bharat, are you happy with the tricuspid valve?
Yeah, happy.
All right, Bharat is happy. Okay, so carry on. Support?
Okay. Yeah. Okay.
Show us the fluoro.
Okay. 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 Go on. Yeah.
Came back.
Open. Good. Yeah. Okay. Fine.
So here, are you using TOE guidance, or are you just going by feel and fluoro?
To pull your pigtail, maybe?
Yeah.
Okay. ตรงเนี้ยYeah.
Stop. One cine.
Yeah.
Yeah.
And how do you
I'm
see
not
it?
sure that you happy with this.
Well, I would be looking at TOE as well.
Yeah. จันรัตน์ครับ
Yep.
Okay. Maybe you put the TOE big.
Yes.
Yeah.
Sorry.
Okay.
It's here. And
And color on TOE?
the white looks stable in it. Yep.
Yeah. Good.
Yes.
And now you can do some angiograms.
Yeah. ต้น Okay. ต้น angel ต้น
And look at the coronaries and the
ดึง
valve.
ขึ้นหนึ่งดึงขึ้นหนึ่งโอเคอ่ะ
Certainly on TOE, it looks good.
The contrast is not enough.
74
Oh, 74. Oh, I'm sorry.
Okay. Ready?
Oh.
Okay. June. What do you think? Some leak.
Yeah. So we're just trying to see.
Yeah, I mean, it looks like, at least on your AP projection, that it's through the device. On the lateral, I'm not quite sure if there's anything around. On AP, I'm more convinced, that it's through the device itself, through the disc of the device. Your TOE also is very reassuring in terms of what that color looks like.
I'm not sure the PA disc, if you want to call it, the pulmonary artery side of it, if it's through the actual aneurysm. I wonder if you can reposition, pull the device a little further back. What do you think, Shaq?
Further back where?
Like towards the right atrium. Try to make that part.
No, I think on lateral it looks quite.
It's opposed to the aorta,
Yeah.
the aortic disc, so it'll be difficult to pull it further.
I think the positioning is fine. Yeah, I think you can change your views on your TE and make sure this, if you can tell if there's leak through the device or around the device. I do think on AP projection it looks pretty
Bharat.
reasonable.
Microphone.
Just a couple of comments. I think incidentally the aortic valve looks bicommissural in this particular patient, incidental finding. In this case, probably, I think because the device is still on the cable, it will adjust itself once you release it. I would wait for maybe 10 to 15 minutes on the cable, just see a repeat angiogram, and if there is reduction in the flow, I would consider this as a foaming and probably release the device. I'm quite happy with the position, unless there is some additional leak which we cannot see angiographically. But I think on transesophageal, the position looks great.
Yeah.
I think we have just occluded the mouth of that aneurysm. Perfect position. I wouldn't reposition this device.
Yeah. On the aortic end, it's nicely opposed, isn't it? So the rest of it has to be through the rupture. And any benefit of...
Jack, just one comment I wanted to make. This kind of residual shunt, even after release, if it persists, the risk of hemolysis is real in these patients.
In that case, what would you do now? Remove this, upsize, or what?
I don't think it would make a difference even if we upsize this, because that level of foaming will remain irrespective, and probably then the chances of distorting the aortic valve will be higher. So I would probably consider this at least on transesophageal echo and even angiographically. I think the position looks really good and the size looks optimum.
Yeah.
Look at the waist on the device, looks really
On
good.
lateral projection and AP, there's a nice
this
waist
side.
there, so it's definitely restrictive.
Yep.
The challenges occasionally is when you have a second defect that you have not appreciated. Once you close the larger one, you see a tinier leak.
So-
That
so-
is what I'm having a harder time with.
Supal, what are you thinking now?
Yeah.
I think I moved the device a little bit, and I think now you can see the disc of the device flatten and concave along with the curve of the aortic sinus already, you see. And now you can see good waist on the body of the device. So I think with this finding, I satisfied with the device position.
And do you want to repeat another
Do you agree?
aortogram or what?
Yeah. Yeah. I think it's
I think
maybe-
it will have the same finding. I think we cannot know until we detach the
Detach, yeah.
cable because the axis of the device is not coaxial with the defect. Right?
Yeah. Okay.
I think we
So-
better deploy the device,
Okay.
detach the cable.
So
Did we assess for the coronary ostium?
It's a long way up.
It's higher.
It appears quite
Yeah.
high.
Is not an issue here.
Okay, so that's nicely released.
yeah. And we check the angle again. Yeah. ต้นเดดิน
ดึกขึ้นได้ปะ
Okay.
Oh, that looks much better.
Yep. So
เล็กไปไหมอาจารย์
bit of
Okay, you
foaming.
can see in the B plane is a LAO plane. You can see the disc of the device curve along with the curve of the aortic sinus and with bulging of the concave of the disc inside. I think it looked good. And also the screw knot at the body is move inside the body and is expand the body fully. Okay, I think I will do nothing now.
Very nice. Hujjat.
If you look at to the right side, there is very tiny residual shunt in the right side. If you look at that,
Yep.
it's possible. Shabana said very good comment, good mention about another very tiny, another residual shunt close to the device, but shape and size and position of the device.
So what
is
would
very
you do?
Good.
What would you do?
We follow these patients, and I hope we have not any hemolysis after this procedure. Just follow.
All right. On the transesophageal echo, could you show us left ventricular outflow tract view and the aortic valve that way?
yes
Just to look at the aortic valve
Okay,
leaflets.
a little bit more comment about the disc. I think my purpose is to have the disc closing the aortic orifice completely, and I think the tunnel of the defect is not like a circle, so the device will need some time to expand, gradually expand to close the tunnel. So I think it should be closed in 1 or 2 days or maybe 1 week or 1 month. But about the hemolysis, I think that it's possible, but I think we need to do nothing, just observe and conservative. Because I think finally it will have no leak and the hemolysis will subside at that time. Thank you.
Can they measure the constriction portion?
Okay. Can you measure the waist on the device on fluoro?
The reason why I'm asking, the sheath was not going so smoothly. In RSOV, many times we see tiny defects which we won't be able to see because of the color which covers that. So if you go through the tiny, because of the sheath and constriction is quite significant, one of the post-procedure TE 45 degrees showed that there is a superior defect which is jetting into RA. So my question is whether we missed the bigger one and then went through a smaller one and then closed it.
So that's not a bad waist on there. It's 6 something.
6, yeah.
6.1.
Okay.
Yeah.
Yeah. And you can see the diameter of the disc by measurement is 14, but you have to think that the disc is not flattened now, it's concave inside. The original size of the disc is 16, so I think it should be okay.
Nearly fully. Okay,
And what I will
Bharat?
Before coming out, I would do 2 things. I mean, not that it would change anything, but I would definitely auscultate this patient to see whether the murmur is there, although we have lost the art of auscultation. And second is look at the pulmonary artery pressures, what has happened acutely. Because I don't find this LV to be that bad truly on transesophageal echo. So that pressure probably is shunt related, and we may have some changes in the PA pressures immediately.
Okay, well, it may be some other disease process going on as well. So, so are you going to remeasure the pulmonary artery pressures as well? Support?
Yeah. We try to
we are going to measure the PA
measure the
pressure.
pulmonary pressure.
Okay, good.
Yeah.
And then we've got 2 or 3 minutes, and then
ลีก
we,
น้อยลงค่ะ
we have to cut away.
มันลีกน้อยลงโอ้ได้นะว่าไม่ต้องทำอะไร
Right.
And it was just a minor point. The coronary arteries are a long way away on that aortogram, so that's one
We
of
can
the
have the
concerns.
LV and diastolic pressures too, just the push of the pigtail catheter.
Yes. Okay, right. กดชีพมาดิ
Yes. Okay. Yes.
Okay, just show us the trace of the pulmonary artery pressure, and then LVEDP, and then we're done.
Okay, this is the PA pressure.
What range is it, or we?
But the patient on sedation and has some secretion because we did not
ก่อนจะหลับ
do the general anesthesia.
Okay. But
That's already,
what
sedate.
sort of reading are you getting? Because we can't see any.
Oof. Is some leak over there?
ลีกน้อยลงดูดีขึ้นเยอะเลย
The PA pressure is systole is 56 over 12, 13, something like that. Yeah.
Okay, and the LVEDP?
DVP is not yet.
Okay, right.
Okay, bye.
Shaq,
Yeah.
if you get to the EKG, EKG showed the right bundle branch block, but do you see the P wave in the EKG? Please show again.
Yeah,
We'll check with them.
Is there P
this
wave
is
or
sinus
not?
lithium. Yeah. This is the P wave. Yeah.
It's slightly longish looking, isn't it?
It look like a
It's
first
speed as
CKAV
well.
block. Yeah.
Do you see the P wave not very clear?
I think it's there, but it may
Better we
speed of
It's
recording
motion
suggests
prayer
it's
procedure to the EKG prayer procedure.
first degree heart block. Okay, what's the EDP?
EDP เท่าไหร่เท่าไหร่นะ
อาจารย์คะ
11.
Okay. All right. Well, so interesting. Thank you very much indeed. That's an excellent example.
Okay, Sudarat told me that the leak by TE now nearly closed already.
Can we see it then?
Okay,
Yeah.
Sudarat, please show.
ให้
Oh, there you go.
อาจารย์
เชิญ
ไม่
เชิญ
ไม่ไม่ออกอาจารย์โชว์ได้เลยค่ะไม่หนูไม่ออกค่ะอาจารย์คะ
So that's very nice indeed.
Yeah.
All right. Excellent. Support and Pontep. Thank you
Okay.
very much. And Sudara.
Yeah.
Thank
Yeah,
you.
you're
Thank
welcome.
you.
Yeah,
everyone.
thank you.
Right.
Thank you.
So thank you for that to all the panelists as well. And I'm going to ask Shiva Kumar, Tao, Gareth, Nick Haas, Pia, and Ahmed Chalabi to take over the next session, which is on hybrid procedures in congenital heart disease. Tao and Shiva.